Hello guys, welcome back to Clinically Clear. Today we'll be covering another very important topic, short, easy, important, that is pterygium. Okay, let's get straight to it. So pterygium is a triangular or wing-shaped fibrovascular fold of degenerative subconjunctival tissue encroaching over the cornea. Now let's take a look at the diagram. So you have a triangular fold or a wing-shaped fold. It looks like a wing of a butterfly. So triangular wing-shaped fold. You have vessels. You have white fibers. So fibrovascular. It is degenerative subconjunctival tissue, and it is encroaching over the cornea. Here you have the cornea. It is coming onto the cornea. So that is the definition. So now let's come to the etiology. Now we don't know the exact cause of pterygium, but we can remember the risk factors through a simple sentence. An elderly male farmer in tropical countries, or you can think of an elderly male farmer in India. So elderly, so old age, male for sex, farmer for occupations where you have increased exposure to sunlight. Example, like a farmer is more exposed to UV rays, no? So mainly it's UV rays. So increased exposure to sunlight. And tropical countries like India where there's a lot of heat, there's a lot of dry winds, increased temperature. So old age, male sex, increased exposure to UV occupations such as farmers, and you have tropical countries where the heat is more or the dry winds are more. So now let's look at why it happens. So basically you have limbal stem cell deficiency. This limbal stem cell deficiency, it causes three things. It causes the fibrovascular proliferation of conjunctival tissue. As I said, it is fibrovascular and it is conjunctival. You can tell conjunctival tissue or you can tell subconjunctival tissue, little interchangeable. And proliferation, of course, it's not always present. It's like growing over the cornea, right? So proliferation. And as I said, it is degenerative fold of subconjunctival conjunctive tissue. And what is the type of degeneration? It is elastotic degeneration. And it is always accompanied with corneal tissue destructions. If it is coming over the cornea, it will also try to destroy the cornea, right? So the top layers of the cornea, like the corneal epithelium, the Bowman's membrane, the superficial stroma of the cornea, they get destroyed. So what are the symptoms? Think about it. First of all, you have a mass in the eye. So when you have a mass in the eye, it doesn't look good, right? So cosmetic intolerance. And let's say there's any inflammation in the pterygium. Let's say there's any infection. Then your eye starts watering. You start having FBS, that is foreign body sensation. You start having irritation, itching, etc. Now, what's more important is the vision loss. See, initial stages, early stages, the vision loss is because of corneal astigmatism. I'm talking about before it comes all the way across onto the pupil. So initial stage, it is growing. It starts flattening the cornea. And when it starts flattening the cornea, there is astigmatism. So due to flattening, there is corneal astigmatism. And what type of corneal astigmatism? As I've mentioned in my astigmatism video, it can be either with the rule or against the rule. With the rule is when the vertical curvature is more than the horizontal curvature. And of course, a pterygium is growing horizontally. So it flattens the cornea also horizontally. So horizontal curvature decreases. So horizontal curvature is less than vertical curvature. So that is why in corneal astigmatism, you have with the rule astigmatism. And late changes, what happens? Gradually, as I told, the pterygium makes its way onto the pupil. So it comes onto the cornea, then it covers even the pupillary region. So that will block, it will cause gross vision loss. It's as if something is covering your eye. So that is late vision loss. And lastly, as I said, pterygium, it comes from medial side to lateral. Usually it comes from the medial side and it goes towards the cornea. So that is where you have the extraocular muscles as well, right? It's coming and inserting onto the eyeball. So the pterygium might restrict these extraocular muscles. So that can cause diplopia because one eye you have restricted extraocular movements and the other eye is moving normally. So let's say I want to look this way. So my left eye is moving that way. It's seeing one image. But let's say I have a pterygium in my right eye. My pterygium right eye is not able to move because of restricted extraocular movements. So my pterygium right eye is still stuck here. So it's looking here. So one eye is looking here, one eye is looking there. So that will cause diplopia, double vision. So that is one more. So that is about symptoms. Next, coming to signs. See, signs. What is a sign? Sign is what you look for. So sign is the pterygium itself is a sign. So the triangular conjunctival fold, that itself is a sign. And the apex, one thing you need to remember is that the apex is always directed towards the cornea. See, as you can see, the pterygium is like this. The pterygium will never ever be directed. It will never ever grow this way. It will always be, the apex will always be towards the cornea. always directed towards the cornea. And more commonly, the pterygium is in the nasal half. Very, very important. Nasal pterygiums are more common than temporal pterygiums. That is because, think about it. What is the reason I told? UV exposure. So let's say UV rays are coming. Temporal side, only these UV rays are hitting. But nasal side, the ones that are directly falling on the eye, those UV rays are hitting the eye. And also, let's say some UV rays hitting the nose, the bridge of the nose. It reflects of the bridge of the nose and it comes onto the nasal half of the eye. So that is why you have more UV exposure on the nasal half of the eye compared to the temporal half of the eye. That is why pterygium is also more common in the nasal half of the eye. And there's a rare condition where you can have pterygium in both nasally as well as temporally. That is known as primary double pterygium. Okay, so that is about, as you can see in this picture here, you have one pterygium here in the same eye. That is primary double pterygium. So now let's look at the parts of the pterygium. So parts of the pterygium, you have the first part is the part present over the cornea. So the part present over the cornea is the head. So over the cornea you have the head, and within the head you have the tip or the superficial whitish tissue over the head. That is the cap. This part here you can see, that is the cap. And then the part over the limbus, the constricted part over the limbus, that is the neck. And last is the biggest part, that is the body, that extends from the limbus all the way to the canthus. This is the canthus, right? So it extends all the way from the limbus to the canthus. That is the body. It is the scleral part. That is one sign. And then one more sign that you can see in a few individuals is something known as Stalker's line. Now what is Stalker's line? Here you can see in this diagram, you have a brown line here. It's a bit hard to see, but you can make it out if you look closely. So you have a brown line here known as Stalker's line. Now what is a Stalker's line? It is a brown line anterior to the head of the pterygium. This is the head of the pterygium. So you have a brown line here. Why is it brown? Because of iron deposition. The Stalker's line is basically iron deposition in the form of a line anterior or just next to the pterygium, the head of the pterygium. So that is about the signs. This pterygium itself, the parts of the pterygium being more commonly in the nasal half and rarely primary double pterygium, and then the iron deposition in the form of a brown line which is also known as Stalker's line. Then coming to the types of pterygium. Now types of pterygium can be classified first based on the extent, how much it has grown. Here you have type 1, type 2 and type 3 pterygium. Now type 1 pterygium, it has come 2 mm over the cornea. Type 2 pterygium, it has grown more. It has come 4 mm over the cornea. Type 3 pterygium, it has come 4 mm over the cornea and now it has also encroached the pupillary margin. Here look at the diagram. Here this is the pupillary margin. So if it comes also onto the pupillary margin, then automatically you can say it is type 3 pterygium. You don't need to measure it or anything. So type 1, 2 mm, type 2, 4 mm and type 3 is 4 mm. Along with that, it also encroaches the pupillary margin. Then based on progression, you have progressive pterygium, regressive pterygium and stationary pterygium. Now what is progressive pterygium? As you can see in the name, it is growing. So obviously it will be highly vascular, it will be thick, it will be fleshy, it will have active fast growth. Whereas regressive pterygium on the other side, it will have very less vascularity. It will be thin, it will be membranous, no, it won't be thick and fleshy, it will be thin, membranous, it will be atrophic. Why atrophic? Because it is not fast growing, it is trying to regress, it is coming down. So that is why it is regressive. Progressive, regressive, based on progression and based on extent, type 1, type 2, type 3. Complication simple. There can be an infection in the pterygium, infected pterygium. The pterygium can get inflamed pterygium. There can be malignancy within the pterygium, neoplasia. Okay, just remember the names, it's fine. Next, coming to something very important known as pseudopterygium versus pterygium. The main differential diagnosis is pseudopterygium. So in pseudopterygium, what happens? The origin. First is, okay, the origin. Pterygium, as I told, is degenerative origin. It is a degenerative triangular fold of subconjunctival tissue. Pseudopterygium is inflammatory in origin, and that too mostly due to acute inflammation. Let's say there is some trauma to the eye, or any burn or any ulcer. What happens? While healing, there is fibrosis, right? So though that fibrosis can cause adhesions between the bulbar conjunctiva and the peripheral cornea. So over the sclera, you have the bulbar conjunctiva, then you have the cornea. So there can be some adhesions between the bulbar conjunctiva and the peripheral cornea. So it appears, those fibrous adhesions, they appear like pterygium, but they are not pterygium. So it is inflammatory origin. And another thing, pterygium will Can you see pterygium anywhere? No. It will only be seen between in the interpalpebral aperture. What is interpalpebral aperture? See, this is upper palpebrae, upper eyelid. Here you have the lower eyelid, lower palpebrae. The part of the eye which is in between the two palpebrae. Basically, the part exposed to sunlight. As I said, it is because of UV exposure. So only in parts exposed to sunlight, only within the interpalpebral aperture. But this trauma, burn, ulcer, and this acute inflammatory changes, pseudopterygium, it can be anywhere in the eye, any part. It need not be only in the interpalpebral aperture. And one of the risk factors for pterygium was old age. Here, pseudopterygium, acute inflammation can happen at any age. And also, pseudopterygium, you can pass a probe underneath the pterygium. So you have the cornea here, and then you have the pseudopterygium coming and attaching. Pseudopterygium, you can pass a probe underneath, but pterygium cannot be probed. Okay, here I made a mistake. This is cannot be probed. You cannot pass a probe underneath the pterygium. Let me just correct it. Cannot be probed. Yeah. So that is pseudopterygium. And then pseudopterygium, it's a result of acute inflammation. So now you have adhesions. So that adhesions it'll always be like that. It won't progress, it won't regress. So it is stationary. Whereas, as I said, pterygium can be progressive or regressive. So this is the main differential diagnosis, that is pseudopterygium and pterygium. The origin, the site, the age, whether you can probe it, and what's its fate, whether it will regress, progress, or it will stay like that. So that is about pterygium and pseudopterygium. Next, let's look at the treatment. So treatment, mainly you have, see, medically, can you cure it? It's a mass. Can you cure it medically? No, there is no cure. But some symptoms of pterygium you can treat. For example, let's say the pterygium is inflamed or it is infected. Then you can give steroids, you can give topical antibiotics, etc. And let's say there's any dryness or irritation, then you can give some lubricant eye drops or stuff like that. And let's say there's an old man who cannot afford surgical excision and he's fine with the cosmetic intolerance. So you don't want it to grow more and cause vision loss, right? So you'll give dark goggles. Dark goggles will eliminate the UV exposure and then it will decrease the rate of growth of the pterygium. So that is about medical treatment, not that important. Main thing is surgical excision. That is the main treatment of choice for pterygium, is surgical excision of pterygium. Now, steps of surgical excision. First step is, see, this diagram, it's not very clear, okay? Like, I think it's better if you guys try to watch like during the OT or something. Even I haven't watched it. Let's look at the steps. That's more than enough. So first step is topical anesthesia. Of course, you're making incision there, so it'll pain. You'll put an universal eye speculum to spread the eyelids, and then you'll sterilize it using povidone iodine, etc. Then always we dissect from the head to the body of the pterygium. So start carefully dissect the head from the cornea. Start dissecting the head. Then lift the body from the scleral tissue and start excising it slowly towards the body. Lift the remaining body and go towards the base of the pterygium and excise slowly. One thing very important is do not damage the medial rectus. Very, very important. Do not damage, because you don't want the patient to go into strabismus or diplopia or anything like that. And of course, pterygium is a fibrovascular growth. So when I'm excising it, when I'm removing it, of course it'll start bleeding. So you have to do cautery to achieve hemostasis. So that is about the surgical excision of pterygium. Now the main problem of the surgical excision, biggest problem of surgical excision is the high rate of recurrence. You will cut the pterygium, it will grow again. You will cut the pterygium, it will grow again. So to prevent, it has a 50% rate of recurrence. Now to prevent the recurrence, there are two ways. There's a medical way and there's a surgical way. Medical way, you will give an anti-metabolite known as mitomycin C. So this mitomycin C will prevent the recurrence. Whereas surgically, if you want to do it, you will put a graft. Wherever you've removed the pterygium, there you have exposed conjunctiva. There is no conjunctiva, you have exposed sclera, right? So on top of that, you will put conjunctival limbal autograft. From the same person, you will take superior part, from the superior part of the eyeball, you will take a little bit of the limbal conjunctiva and you will put it where the pterygium was there. Conjunctival limbal autograft. Commonly, you can see, they refer to it as CLAG, conjunctival limbal autograft. If limbal conjunctiva is not available, you can even graft amniotic membrane. Now, you can't just simply place the graft there. You have to either suture it onto the sclera underneath, you can put fibrin glue, and recently they have started to use even patient's own serum sample. just a few drops of the patient's serum, itself acts like a glue, and then it makes it stick to the part where the pterygium was excised. So that is about how to prevent recurrence. So that's it for pterygium, guys. Thank you for watching.